Right, so as we know, there's an increase in drug resistance worldwide, and it's becoming a major problem. So it's becoming increasingly important to use antibiotics in the way they work best. So what we have here is we looked at meropenem and piperacillin-tazobactam, so two beta-lactam antibiotics that work by having their drug concentration above the MIC, the minimum inhibitory concentration, for as long as possible. So theoretically, it would make sense to extend the duration of infusion of these antibiotics. So instead of administering them over short boluses, like 30 minutes to 60 minutes, we implemented at the University of Minnesota Medical Center a protocol where we would infuse these antibiotics over an extended infusion. So with meropenem over 3 hours, and with piperacillin-tazobactam over 4 hours. And then so we collected data prior to the implementation of the extended infusion and then post-implementation of the extended infusion. And so that's kind of the methods we have here. If you want to catch the dosing we use, we adjusted for indication as well as for renal function, as both of these medications are renally cleared. And then I will let Lacy, my co-resident, fill you in on our results.
Okay, so I'll have you just kind of focus on the demographics. Realistically, this one over here, sorry. The demographics, so we did the intermittent versus extended, and really nothing too statistically significant between the two except for this CRRT, or chronic renal replacement therapy, was the difference between the intermittent and extended, more in the extended infusion, which was statistically significant. Just to kind of highlight, the predominant indication in these patients that we were treating was pneumonia, and then we can kind of scroll down to the mortality, which was our primary outcome that we assessed. And if you look, we have on the y-axis event-free survival, and the x was basically looking at the days or time till death, and basically we have the extended in blue and then the intermittent infusion. And so what this is showing us is the time to death based on the dosing scheme, and there was a faster progression towards death in the extended infusion group. We also broke it down based on drugs, and so as you can see here, we have our extended infusion meropenem, and then in the red was our extended infusion piperacillin-tazobactam. Most of the results were driven by the extended infusion meropenem, but we did see both extended groups had a trend towards faster progression to death, which was statistically significant for the extended meropenem. We broke our secondary outcomes down, which is a hospital length of stay and ICU length of stay based on drugs. So on the top is the meropenem, and then on the bottom is piperacillin-tazobactam. And so what we saw from meropenem was we had a longer both hospital and ICU length of stay for both. And we didn't see that for the Zosyn group. Nothing was statistically significant. And then for other data as well, we saw when we combined it, the only difference really was in the length of stay. But otherwise, that was pretty much it. Our predominant organism was Pseudomonas. But really, when we look at the data and analyze it, 10 of the 56 deaths had cultured organisms, gram-negative organisms, so we can't necessarily link organism with causality of death. So, although, just kind of to wrap it up, we had theoretical benefits with this dosing scheme, but unfortunately with our results, I think it just promotes more studies in this area and really looking at a randomized controlled trial.